Welcome to our channel, AMC Learner. Hello everyone. Today we will be discussing a very important topic relevant to the AMC, which is asthma. We will be covering all the important points and I will let you know the things you have to read from the John Word. Only the stuff that I tell you would be sufficient for the preparation of AMC. Let's start. What is asthma? Asthma is basically a type of obstructive lung disease. Obstructive lung disease means FEV1 over FVC ratio will be decreasing, which will be less than 70%. On the other hand, the residual lung volume and the total lung capacity of the lung would be increasing. This is an inflammatory disorder. From the first page, as you can see on the screen, you just have to give a quick read to the key facts and checkpoints. There is nothing important, but do give it a read. Pathophysiology, no need to cover it for the AMC. Causes of asthma are really important, and most important that do come in the exam is the drugs causes causing asthma. Aspirin, NSAIDs, beta blockers. But ACE inhibitors also cause dry cough, as you all know, and ACE inhibitors we cannot recommend in patient with asthma. Do remember this as well. Moving on to the clinical features, we all know that wheeze, cough, tightness, breathlessness are the main and common symptoms of asthma. Now, most important thing is investigations. Investigation, the key investigation is spirometry, but the thing to remember is that we cannot perform spirometry below 6 years of age. This too come as an MCQ point. Spirometry is not recommended below 6 years of age. Below 6 years of age, we do chest X-ray to rule out other causes or complication, but spirometry is only recommended after 6 years of age. What a spirometry will show? It will show that FEV1 or our FVC ratio is below 75% which will be obviously indicating the obstructive type of lung disease. Next test is reversibility test. Reversibility test is a test we perform with salbutamol. We give patient puff of salbutamol, and in case of asthma, the FEV1 ratio will improve by greater than equal to 15% after 20 minutes of salbutamol inhalation. Next are chest X-ray just to rule out the complications. Moving on to the next significant historical advances, just give it a read. The most important point in it is that sodium chromoglycate is also available as an inhalation form. So this too comes as an MCQ sometimes. Next are reason for suboptimal control. Do give it a read of the medical condition associated with it, because sometimes they do test. For instance, they test that patient has chronic cough and known case of asthma. So which medical condition can be associated with it? So in the options, all of different options can be given. But most important association is with GERD, which is 30% association. Okay, next is our principal management. You know, the table in which there is classification mentioned intermittent, mild, persistent, moderate, severe. You have to do it. You have to do it by heart. You have to remember this table. But I will tell you a flow chart, just a quick review of how to manage asthma in children as well as in adults according to the guidelines. Okay. So stepwise management of asthma in children 6 to 11 years of age. As we all know that first step is just we give patient SABA. SABA is the acute reliever. In each and every step, SABA is necessary and compulsory. SABA PRN as needed, we have to give patient. Next step, if patient is not controlled with SABA, then you can add low dose steroids or you can give patient with Montelukast. Okay? Then, if patient is not controlled with this, you can increase the dose of inhaled steroids Or you can give patient low dose steroids in combination with montelukast. The next step would be high doses of inhaled corticosteroids. And on the last step, we can add high doses of inhaled corticosteroids with LABA. This is the management for children 6 to 11 years of age. Now for adults. For adults, you have to give SABA PRN as needed. Then you can add low dose steroids. You can add low dose steroids with LABA. Then you can increase the dose of low dose steroid to moderate to high dose of steroid with LABA. And if patient is still not management, if patient is still not managed, you have to refer the patient to the specialist. Moving on to the management of status asthmaticus in children as well as in adults. First of all, we will discuss about the management of status asthmaticus in adults. So, what are the signs of status asthmaticus? Patient is breathlessness. He has difficulty in speaking. He is drowsy. He is confused. Respiratory rate greater than 25. Pulse rate greater than 120. His chest is silent. First of all, you have to call the ambulance. Then the next step would be you have to place the patient in the proper position. The next would be you have to give salbutamol puff, one puff followed by four breath. Wait for 4 minutes and then you can repeat the puff of salbutamol till the time ambulance arrives. In hospital, you have to give patient continuous nebulization with salbutamol. If saturation is below 90%, attach oxygen 6 to 8 liter per minute. Then give nebulization with ipratropium bromide. On the next step, you add magnesium sulfate. If still not management, if still not managed, give IV or oral steroids. As IV and oral steroids has equal role, then you can add adrenaline on the next step if patient is still not managed. Then shift the patient to intermittent positive pressure ventilation. This would be the management for the adults. Moving to the management of children, first you have to see the attack is mild, moderate, or severe. Mild would be infrequent attack. Infrequent means greater than 6 to 8 weeks apart. In that case, you have to give only SABA, PRN as needed. In moderate attack is less than 6 weeks apart, which is kind of troublesome to the patient. You have to give SABA, but in this case you have to manage according to the age. If patient is less than 6 years of age, you have to give 6 puffs of SABA and you can repeat 6 puffs of SABA 3 times. You can add 4 puffs of ipratropium bromide along with SABA. If patient is greater than 6 years of age, go for 12 puffs of SABA. You can repeat this 3 times and then you can add 8 puffs of ipratropium bromide, and you can also add steroid. Steroid is not recommended in less than 5 years of age as it hamper the growth. This is an MCQ point for the AMC. Now moving on to the severe asthma. Severe asthma is most days, patient suffers from that attack of asthma. So in this case, you have to admit the patient, you have to give him oxygen via the nasal prong at 2 to 4 liters if saturation is below 90%. If less than 6 years of age, again SABA 6 puffs, ipratropium bromide 4 puffs. If greater than 6, SABA 12 puffs, ipratropium bromide 8 puffs, followed by IV magnesium sulfate, followed by IV steroid. If still not managed, aminophylline, adrenaline, and then intermediate positive pressure ventilation. This is the stepwise approach in case of severe asthma. In case of exercise induced asthma, you have to give patient 2 puffs of SABA 5 minutes before exercise. If patient is not managed with SABA only, then you can add montelukast, and in the next step you can add steroid. This is the stepwise approach for exercise induced asthma according to the guidelines. Okay, moving on to the next. Give a quick read to this table: mild, moderate, severe, persistent. Give a quick read to good asthma control. Um, Bronchodilators are basically relievers. For the prevention of attack, we give anti-inflammatory drugs. So, what are reliever? Reliever are bronchodilators, which include SABA, and preventers are basically anti-inflammatory, means steroid. This table is really important. Generic type examples, nebulizing, oral, really important in a sense that in methylxanthine, we have to monitor the BP of the patient because it lowers the BP. For below 5 years of age, as I have already told you, that we do not give patients steroids as it hampers the growth of the patient. So we try to avoid it. Just give a quick read to this chart. Nothing much to remember. Moving on, um, do give a read to the preventers and treatment of the asthma. Nothing much to remember. The things we have discussed are more than sufficient. Do give a read to exercise induced asthma. It is really important, and question do comes from this topic. Then moving on, do give a read to the stepwise approach, and dangerous asthma is also really important. Give a quick read to thunderstorm asthma as well. Uh, the guideline for spacer we have already discussed: less than 6 years, 6 puffs, and greater than 6 years, 12 puffs of asthma. Asthma in children, to give a quick read, we have already discussed all of this. Mild, moderate, and severe attack, we have already discussed. So that's all from asthma. There are some few MCQ points as well, like uh, like respiratory failure. In type 1 respiratory failure, there is hypoxia, but in type 2 respiratory failure, there is hypoxia and hypercapnia as well. Indication of mechanical ventilation in asthma. There are two indications. If saturation is below 85% and if patient has hypercapnia, these two are the indication for mechanical ventilation in asthma. Then there are some level A evidences, like oral steroids are equal to IV steroids and the spacers are equal to nebulizers. Level A evidence means there is not much difference between oral and IV steroids, their mechanism of action, their effect on the patient of asthma. So, these are some of the MCQ points. That's all for asthma. Do subscribe our channel and let us know which topic you want to discuss next. Thank you.